All right. So today what we're going to do, I'm going to give you a little bit of background about mass support and the work we're doing during COVID-19. And then the majority of our time, I will turn over to Sean, who's going to talk with you all about the vaccine and how it works and what it means for thinking about things like regathering. We'll end the time with some questions to consider about kind of a theological consideration to think about regathering, and also some questions for us to think about ourselves as leaders and the kind of mental and emotional state that we might be in as we prepare to make some of these decisions, and tell you about some resources that are available. As I was saying a little bit before we started, Carl Carl from PNNE, and I will be co-hosting a follow-up to this in 2 weeks. So on March 17th at 11 a.m., where there'll be much more time for talking and interacting and sharing kind of what's happening in your community and what your ideas are. So mark your calendar for that, and there'll be information about that in Presbytery newsletters. So let me give you my brief dog and pony show about mass support. So mass support is funded by FEMA. After COVID was declared a disaster, money was released from FEMA for statewide crisis counseling programs. That's the official name for what we do. And we are also managed in partnership with MEMA, that's the Massachusetts Emergency Management Association, and also DMH and Riverside Community Care. And what we provide includes brief one-on-one support services for any resident of Massachusetts. We do psychological first aid and skills for psychological recovery. We also provide referrals or help you to make those connections to ongoing services as needed. We offer what are called coping groups. This is a evidence-based practice. It's an hour and a half long group process that helps people who've been through a potentially traumatic event like a disaster to process what they've experienced and to build on their own resiliency and coping skills. This might be something that you would be interested in doing, and we'll talk more about that later. We also do educational presentations just like this one today and on a bunch of different topics. So all of our services are free, anonymous, and confidential for any resident of Massachusetts. Now, I know there are some other states that get included in the group that's here today, and so I have some information for you as well, but just for those in Massachusetts, here's the information. Anyone can call this number between 8 a.m. and 8 p.m. Monday through Saturday, leave a message, and then we will respond as soon as possible, usually within a few hours. And there's also coverage available in multiple languages if that's a need that people in your community have. If you're in Vermont or New Hampshire or Maine, these are where crisis counseling programs are based for your people, so check in with them. I think that Vermont and Maine have very similar programs to ours where you can call in, and New Hampshire has done a lot of work with local and existing mental health organizations. And that is the end of my spiel. Stop share. And I'm going to invite Sean to introduce himself to you and to take it away.
Hi, everyone. My name is Sean. I am a registered nurse working mainly in psychiatric medicine. And I've been kind of the person in charge of following the medical side of the pandemic for mass support. I do a weekly, sometimes bi-weekly update on the state of the pandemic for the team, which we also put out on YouTube for anyone who wants to keep on top of things without having to follow the news. And today I'm going to talk about the vaccine, how it works, some frequently asked questions, and what that means for getting back together. So I'm just going to jump into that. If you see me looking down, it's because I'm reading my notes off my phone, which is precariously balanced on my laptop, which is precariously balanced on a laundry hamper, because I recently turned in my laptop for a new one and found out that the camera will not work at all if I'm even slightly backlit. So I have to do things here instead of on the large elaborate desk behind me. With that said, let's get going here. And as Megan and I discovered a little while back, I cannot see anything in the chat while I'm screen sharing. So if you have any questions, please put them in, and Megan will kind of filter them. If there's anything urgent, Megan, jump in and interrupt me, because otherwise I will not see it until the end of the presentation.
Sounds good.
I will see that you're chatting and just assume that it's something about me and become anxious. But anyways, let's get going here. Come on. Okay, so how the COVID vaccines work. So first, think of your immune system like a boxer. It's a decent fighter, but it doesn't learn anything until it actually gets inside the ring. Against a new opponent, it's going to take a few punches, but then it quickly figures out their moves and it's going to win the fight. Most of the time, this works out pretty well because its opponents that can't really mix up their boxing style on the fly. So once it knows the other person's moves, it wins. Now, that turns out kind of poorly if your opponent turns out to be Ivan Drago. Learn by doing is not a good strategy against a deadly virus. So this is where vaccines come in. It's basically like a practice opponent for your immune system. The first vaccines used a weakened virus, so the real thing comes along and your body is ready for it. It's gone through a few bouts with a easier opponent and can win hands down. And you can decide who's the vaccine and who's the immune system in this picture based on your own desire there. So while weakened viruses are good in some cases, most of the time we don't need to inject people with a living virus. A dead one will do just as well. In our metaphor, that's basically a punching bag. The immune system still gets the training that it needs, but it's never going to get hit back. Of course, punching bags are big and heavy, and they take up a lot of space, so they're not always ideal. So what the latest vaccines figured out is you don't need the whole virus. You just need the part that your immune system is trying to punch. So in an analogy, this becomes one of those little speed bags you see boxers working on at the gym. So with the Moderna and the Pfizer vaccines, they use messenger RNA to make only the part of the vaccine, that spike protein, that it on the outside of the coronavirus cell, not actually a cell, the virus, that your immune system is actually trying to target. So those spiky proteins, the vaccine is basically sending your immune system the instructions on how to make those. Basically, like you are faxing this guy's boxing gym the blueprints for a speed bag. So the vaccine goes into your body, your cells make their own spike proteins without making an actual virus. Your body gets to train its antibodies, its immune system on those. So when the real thing comes along, you can fight those off without having to ever have a real live virus in your system or even a dead one, which takes a lot longer to produce. The Johnson & Johnson vaccine, which was just approved over the weekend for emergency use, does it slightly differently. It basically takes another vaccine and tricks it into producing spike proteins instead of itself. And that's where the metaphor kind of falls apart. It's someone walking into the gym in a trench coat, and then they open it up and they turn out they're just made out of speed bags. The metaphor doesn't really extend that far. But so when we're talking about vaccine, there are a lot of questions about how it works. So I'm just going to dive into a bunch of the most common ones right here. So first one is, of course, can I get COVID from the vaccine? And the answer is no. The vaccine does not contain any live virus. Actually, they don't. The Johnson & Johnson and the Pfizer and Moderna vaccines don't even use the whole virus, and the Johnson & Johnson one doesn't even use the same virus. So the side effects you feel, though, are your body testing its defenses. Those are not infections. Anything you feel afterwards, that's basically the test run your body is doing to prepare for an actual viral infection. You can still get infected early on, however, in process. So there have been some people who, say, got exposed to COVID the day before they got their vaccine, had side effects, and they didn't realize what things they thought were side effects continuing on were actually symptoms of the virus that they had contracted before they actually got vaccinated. So that is a possibility there. Speaking of which, when do you actually get full protection from your vaccine for the virus? Because the day after the shot, you're not going to have any more substantial protection than you did the day before. And it's basically about 2 weeks after your second dose with the two-step vaccines that we're mostly using right now. After your first dose, protection is thought to plateau around 50%, though there is some thought that it could actually get a lot higher with recent studies. However, that's not likely to be an issue for anyone with the two-step vaccine because you're going to get your second dose when 3 weeks to a month later, and that grows to about 95%. Note, this is protection from significant illness, not from getting an infection at all, which leads to the next question. A lot of people are asking, can you still pass on COVID after vaccination? The answer is possibly. We don't have enough information on this yet. Because it's possible that you could, in theory, get infected with the virus. You don't suffer any serious symptoms because you're protected against it, so it doesn't bother you much at all, but there is enough in your system to reproduce and that you could then spread. Now, most vaccines on the market, like previous vaccines, prevent transmission altogether. Measles vaccines, for smallpox, that's where there's no more smallpox because it doesn't matter, it just stops it completely. But not all vaccines. Pertussis, there's a polio vaccine where you can still transmit it even though it doesn't actually bother you at all. There's just something to be aware of there. It should at least reduce transmission rates. There is early data that says that there is some significant reduction in transmission, but how much is still an open question. Generally speaking, if it reduces you to the point that you have no symptoms but still have the virus in you, you're going to be doing less transmission than you would otherwise, because if nothing else, if you're not sneezing, if you're not coughing, you're not throwing out a lot of virus into the air. So that's just one way that it will definitely reduce some transmission there. There is still wear a mask, still wash your hands even after you've been vaccinated. We'll get into that a little bit more later. This is another big one that people have been asking, is that can messenger RNA vaccines affect my DNA? And the response to that is no. That is not how DNA works, first of all. And even so, messenger RNA in the vaccines doesn't actually interact with your own DNA at all. It enters a different part of the cell. And if you liken it, we have time later on, I can give you a lengthy metaphor about how that works. But the short answer is it does not touch your DNA and it does not affect your DNA, and it wouldn't even if it did. So lots of no's across the board there. Right? A big one we have, since this has been a huge undertaking, these vaccines have come out so much faster than any vaccine in human history, with the possible exception of the original Edward Jenner vaccine, which he made in an afternoon. Was vaccine development rushed? So it has not been rushed in any way that affects safety. First of all, mRNA technology has existed for years, and the trials move pretty quickly for several reasons. Some phases were done simultaneously. Like we started some human trials before we finished the animal trials. We also took a lot more risk financially by some companies setting up their manufacturing facilities before they had finished testing them. Normally, you would never build a factory to build a product you didn't know if it worked or not yet. But with a lot of government money flowing in to cover that risk, companies were able to just basically make factories before they even knew if their vaccine was effective. And when they turned out to be effective, they were good to go. That's why Pfizer and Moderna are pushing out so many right now. Johnson & Johnson didn't exactly go that route, and that's why their vaccine, even though it just was approved, it's going to be a lot slower to get out. But we can talk more about that later. Another issue was that the scale of the pandemic meant the results came back faster. If you were taking a vaccine for a disease that is a lot less common, say hepatitis, you could give that to thousands of people and you'd wait years to see a number of those people get hepatitis. With millions of people getting COVID every day, it made it much easier. The placebo group started to rack up infections pretty quickly, and we could compare to the vaccine group, which was not. That made it go a lot faster, unfortunately. And also, of course, regulatory prioritization. just a lot of red tape has been cut. These projects jumped to the front of any line they were in. Anytime they were put through, they did go right at the top, though they didn't actually skip a lot of any stages on that. They still had to go through the same approval processes they always did. In fact, when Pfizer, Moderna, it was Pfizer first, when their vaccine came up in the US, there was actually some criticism that the FDA took too long reviewing it, while the British group of the same responsibility moved a lot faster. But again, they're going through all the steps. They're not just looking at the data the company is giving them, they're taking independent scientists and looking over the safety data and effectiveness data. So you've probably heard about some severe allergic reactions in response to the vaccine. So if you have allergies, maybe asking, is it safe for me to take these? And the short answer is yes. The odds of an allergic reaction are about 1 in 200,000. It's actually a bit less than that now, I believe, just with the number of vaccines we've been giving out there, because we've been doing almost 2 million vaccines a day in the United States. And I have not been seeing reports on 10 anaphylactic reactions a day as well. So you are, in fact, more likely to be struck by lightning or attacked by a shark than get an allergic reaction to one of these vaccines. Also, allergic reactions are extremely treatable. If you're getting the vaccine, you are probably going to be surrounded by nurses at the time, and there are plenty of EpiPens on hand. Allergic reactions are very quick. They tend to happen on average. The average one happens within 10 minutes of being there. So most vaccine clinics will ask you to wait 15 to 30 minutes. On the longer end, if you have a history of allergic reactions. But there have epinephrine there that can quickly treat you. Whereas it's worth noting that about 1 out of 100 people who get COVID will die from it. And those odds are a lot worse than 1 out of 200,000. So new variants, very much on the news. So will a vaccine work on the new variants? The answer is, for the most part, yes. The vaccines have been tested against both UK and South African variants and is protective against both. I put the little asterisk there because it is going to be less effective against the South African variant, but still effective enough to prevent severe disease, hospitalization, and death. Which is, again, I forgot to update that line again from the last presentation, Megan, so I apologize. But COVID is going to have to change a lot more to get around the protection, even if you could still get a mild or moderate case of COVID-19. You're not going to die from it if you've gotten the vaccine, because the spike protein has not mutated enough. Now, it is possible that future variants might be less susceptible. The P1 variant out of Brazil is showing that there is some possibility for reinfection with that. So that one is something that we need to keep an eye on, as it may be significantly less effective. The vaccines may be significantly less effective against it. This is why rapid vaccine deployment is important, because it gives less time for new variants to emerge. However, fortunately, with these mRNA vaccines are very quick to develop. Moderna already has a variant-specific booster in the works, not only in the works, but in testing right now. They can turn around new vaccines in about 6 weeks with this technology, which is very, very cool. We can get these out very quickly. And also, this is looking at the Johnson & Johnson, which you may have heard was less effective against presenting disease with the variants there. It was a test in different areas, one which was South Africa. But if you look, it was still 100% protective against death. So its thing is, if you get the vaccine, COVID won't kill you. You probably also will not be hospitalized for COVID, and that will prevent strain on the hospital system, which means that other people aren't going to die as well due to lack of hospital resources. So that's important. So with that, you may also be asking, which vaccine should I get? And the answer is whichever one is offered to you first. Pfizer and Moderna, there's functionally no difference between them that you're going to care about. The Johnson & Johnson has some slight differences, but the just logistics of it mean that in Massachusetts, we're probably not going to see any of it for a couple of months in any significant quantity. So whatever they have at the clinic, take. There's no appreciable difference between the protection in terms of protection against severe illness and death. And it's really going to vary by region what's getting there. Variations in storage requirements are really what determines it. Pfizer needs to be a lot colder than the others. The Johnson & Johnson can be basically stored in a dorm room mini fridge for a couple of months and is fine. So once that gets out, that'll probably be a large number of the vaccines we're giving. But it's worth noting that of all these trials, of all the different vaccines out there, including 2 others, which are we haven't seen in the United States yet, no one's been hospitalized, no one has died who were vaccinated in the trial. So that's the important part there. So so quickly looking at the rollout, we are partway through phase 2 here. Should be starting up soon on other essential workers and then people with one comorbidity. And if things continue to go well, in April, we'll throw that open to everyone. And that may be a little bit of a little bit chaotic at that point, but hopefully we'll have the infrastructure in place by that point. So I want to talk quickly about herd immunity and what that means. Basically, you may have heard about this, talked about a lot in the news. The short version of it is a virus that has nowhere to go goes nowhere. If enough people are immune, it can't spread effectively. When immunity, that is the number of people who have protection against a disease, passes a certain threshold, the virus effectively stops transmitting. This protects those who are vulnerable, who perhaps can't get vaccinated. And it's worth noting this has never actually happened without vaccines. In the past, diseases would go through an area and then they would come back a couple of years later. Vaccination helps us keep this herd immunity threshold percentage up. So looking at this graphically for a second, here's a population of people. Suppose this person over here is vulnerable and this person is infected. The disease is eventually going to work its way through the population until it gets over to them. Just transmission person to person, et cetera. However, if we were to take the same population and vaccinate a certain number of people, there may still be localized outbreaks, but the disease isn't going to be able to spread over there. There just are basically fire blocks. Like think of when they cut down trees to stop forest fires. It's kind of like that, except this is like coating trees in asbestos, I guess. However, this is a very fragile system because if you just add a couple more people to the population, the virus can find new pathways through. So that's why it's really important to keep vaccinations up. This is why when a couple of people stopped vaccinating their kids for measles for a little while, measles came back. We had outbreaks at Disneyland, for example. So the big question in everyone's mind, when can I do all the things? And that's a little complicated. There isn't a good straight answer yet because we're still waiting to find out how much someone who's vaccinated can spread the virus to someone else. So first, if you've been vaccinated, which precautions need to be continued? And of course, the answer is all of them. You should still wear your mask because if you can transmit the virus, putting a mask on yourself will prevent anything from spreading out there, preventing most things from spreading out. Keeping distance will also dilute dispersion, which is important to just reduce the amount of viral particles a person can put out in the air. And if you are vaccinated, all of these strategies will be much more effective than they were normally at preventing you from spreading to other people. And of course, improving ventilation just helps reduce aerosol spread, which is a big factor in indoor spaces. All right, so maybe not all the precautions because there were several that were never really necessary in the first place. Things like temperature checks, which are useless. Disinfecting surfaces, which are very rarely useful. And wearing gloves, which honestly is just another way to spread disease, but just not in your actual hands. We can talk about any of those individually if anyone wants to, but so when you're talking about the risks of gathering, if you look at these two groups, on the left, we have one person who's vulnerable, on the right, we have one person who's vulnerable. How is the risk of this person change if there are vaccinated people in the group? And the answer is not really any. If there are infected people in the group, the presence of vaccinated people are not actually going to protect them in a small circle. It'll protect them on a population level, but face-to-face, it's not going to do anything there because your vaccine protects only you. And in the beginning, we talked about masks, how my mask protects you and your mask protects me. Vaccine just protects me. So that's an important thing to be aware of. Now, of course, the more people in a group that are vaccinated, the less likely it is that someone who's infected will be in the gathering. So if everyone in a group has been vaccinated, and they've been at least 2 weeks since their second dose to get full protection, then gathering risk is fairly low. But there is still a risk. If anyone has a vulnerable family member, they could still be at risk. The big question mark we have is if we have this group here, if the people only interact with the ones next to them, right? So an infected person interacts with a vaccinated person who interacts with a vaccinated person who interacts with a vulnerable person. We don't know what the risk is of that being a transmission. Now, it should be low. The more vaccinated people in the chain, it should get lower because there's more protection there. But there is still that possibility that is kind of slim. When we talk about, though, where we're going to get to with that, by the end of March, we are supposed to have enough vaccine for 130 million people. And this is full doses, not just like individual doses when you need a two-step vaccine. This is enough to fully vaccinate 130 million people. By the end of April, we're looking around 220 million, and the end of July, about 400 million. Which is, you may note, more people than are in the actual United States. And this is data I filed yesterday morning. Yesterday afternoon, President Biden actually upped this timeline a little bit. There weren't really numbers attached to it, saying that anyone who wants a vaccine by the end of May will be able to get one. So that is, however, with these all this vaccine is great, but it doesn't do anything if we don't have the equipment for it. If you see there, this is a timeline the New York Times put together showing our current pace of vaccination, and when we'll get to different percentage points there. So it's 50% of people would be vaccinated by June 22nd. So we need to get vaccines where they're needed. We need to have trained vaccinators where they need to be. We need an easy and equitable enrollment system, and we have to have people accept the vaccine. And we need to speed up some of those. We're doing about 2 million vaccines a day right now, hoping to push towards 3 million. And the more vaccines we do each day, the faster this gets done, especially as a lot of states are right now reopening, which may trigger a rise in cases as well. So that's about 20 minutes of me talking. So I'm going to wrap up there. We can, next part, are any questions? I'm just going to plug quickly. Next week, Thursday at 7 p.m., we are doing a town hall on the vaccine with a lot of really exciting guests, some of the state's top experts here. So come and join us if you want to see more or ask questions of people with a bit more credentials than myself. And it should be an interesting conversation. And I'll leave it there with our social media for anyone who wants to find us online for any more stuff from the Mass Support Network.
Thank you so much, Sean. I think that the group, they took to heart your admission that if you saw the chat flashing, you would assume they were talking about you and get nervous. So nothing in the chat. That was a lot of information in a very short time. Are there any questions? We could take a couple right now. Some applause.
Sean, I have one question. This is Richard from the Cernios Group. I'm a regulatory researcher and industrial hygienist. Are you saying that gloves, and others are unnecessary because corrugated and other surfaces are not likely to sustain live particles, and that they can't survive, in a dry environment? What is the data that shows that a surface can't maintain a live particle?
So gloves are good in specific circumstances, but it's more people's behavior with gloves that is the issue. It's not that see, since you don't get coronavirus in your hand through your hands, you can get it on your hands but not through them. Also, transmission via objects is a lot less, but just generally speaking, people who put on gloves to, say, go to the grocery store will put on gloves and they'll still touch their phone, they'll still touch their wallet, yeah. So it's more like the way that people use them doesn't help. If you have, say, a family member who is infected and is isolated in another room and you want to do their dishes or their laundry, yes, certainly wear gloves. But most of the time people have been putting on gloves for day-to-day life just isn't a situation. It's just you have an extra layer of skin on your hands that's moving virus from one place to another.
It's just a matter of not touching your eyes. That's one thing that a lot of people don't cover. My question was, where is the evidence? I'm sure that there is, that on a dry surface, on a cold surface or a warm surface, is it thermostable? Is it thermolabile? And can it survive in a dry environment over time? Have you been any tests of that? whether it's
Uh,
concrete, corrugated, mail. Um,
That's a little bit outside my wheelhouse. I do know most of the early studies on transmission on objects, looking at surface types, were a little, say, just not just overreported, but overstudied. Like they put far more virus onto surfaces than would ever actually happen in real life, and so they gave results lasting a lot longer than were generally
okay.
that were generally would happen in the wild. So it can last for a while on surfaces, but at the same time, it's generally in smaller amounts, and it's just has never really been shown to be a major driver of spread. Whereas aerosol spread, which doesn't get quite as much talk, has been a huge factor in a lot of places. Basically, anywhere that there's an enclosed place with people inside of it has led to aerosol spread. And that is a way that super spreading events happen.
Yes, but I mean, transmission by, rubbing your eyes after touching the surface or just touching your eyes in general, isn't that a transmission route?
It is, in theory. It's never been a lot of good data on that, and partly that's because from day one people were washing their hands right away, and still keep washing your hands, because we weren't washing our hands enough to begin with. Now we're basically at the level where we should have been all along. But a lot of the surface like disinfecting we've been doing has been kind of unnecessary. It's been ignoring the major routes of transmission. When you're like grocery stores, so they make a big show of wiping down the conveyor belt before you put your groceries on it. Like the odds that there's virus on the bottom of your box of cereal that touches the conveyor belt, then later that comes around, touches someone else's box of cereal, and you pick it up and touch that same spot, and it's alive that long. The transmission rates are so much less there that it's like if that was a major driver of transmission, we wouldn't be having this pandemic right now. I had a question in the chat that was, we most likely have enough vaccines by the end of May, but what about syringes? That's an excellent question. I don't know that off the top of my head. I have not heard any concern about running out of the actual vaccination materials. So that doesn't seem to be a major concern at the point, but I would not be surprised if we run into some shortages at some point. I know that some of the materials there are making some adjustments for. Moderna is, for example, trying to put more doses into its vaccine vials, so we have to use fewer of those, which also means you get more in a smaller package, and it makes it easier to ship out. But I haven't heard anything about a shortage of syringes at the moment. And someone asked the minimum percentage of vaccinated people to consider for immunity. That's an excellent question. We still don't know about that. Most people have been speculating somewhere between 70 to 90%. And this varies from disease to disease, so we don't really have a good marker for it. And that's, that's unfortunate. But as the percentage gets higher, we should see rates decline. But then somewhere we hit that magic number, and it's hard to say what. Last summer, there are a lot of people making very optimistic estimations, saying something like 20%, and that'll be it. And of course, we've had more than enough people like that infected to know that's not quite the case. But we are actually getting close to 20% vaccinated here in Massachusetts, so we're well on our way with that. But yeah, 70-90% is generally the thought. Let's see. Is a question, is CZ who watching mutation rate for spike proteins? A bit. Unfortunately, the genetic sampling, I believe is the term, I may be confusing with something else, but the genetic surveying, there is a process of just generally surveying the genetic codes of viruses that are circulating. And this is part of how we figure out the flu vaccine every year. The problem is the United States, we've never really done it that well or that much. A lot of other countries have done it very, that's how in England we found out about the B117, because they do a lot of it over there. We're still picking up the pace here. Now they've started doing more of it here, but unfortunately it doesn't seem like it might be enough just yet. hopefully we'll get enough that we can really monitor how these variants are spreading through the country, because when they're more transmissible, it's very likely there'll be a larger portion of new cases. And yes, someone pointed out percent will also vary for the variants. That is quite true. More infectious disease will require a higher level of immunity. To point out, yes, herd immunity is sometimes a controversial term. People don't like being compared to cows. Some people use the phrase community immunity, and they like that because it rhymes. I find that the rhyme a little awkward to say. Population immunity is sometimes also used. Then someone asked about how effective are monoclonal antibodies as therapeutics. So that varies. They've been found to be very effective if used very early. Monoclonal antibodies are basically taking the antibodies your body would produce, or one's body would produce, and putting them into a shot and giving them early on. It's sometimes called passive vaccination, because your body doesn't actually learn anything in the process. It's basically giving your body a fish instead of teaching it to fish, to use the old saying. And they're very effective early on. They are less effective later on. So that's kind of makes them a little tricky. It's kind of what you might call post-exposure prophylaxis is the only term. You're exposed to COVID, they can give you a shot to reduce the effects you might have. And that can be effective, but they are very expensive. So I don't know much about the distribution of them. Also, it's about the available by prescription. So they're kind of harder to come by. I know there is a new push to start getting more therapeutic drugs that are a little easier for the earlier stages, antiviral drugs and such. And how do we address the concerns of people of color? That's a great question. There's a lot of, there's a lot of concerns there. Whether it's concern about getting the vaccine to people who need it, who are disproportionately affected. That's an excellent question that has not really been answered well, especially with a lot of the enrollment being online and with the website struggling a lot. This does make it difficult for a lot of people to get access to the vaccines, even if they are in a priority group. But there's also concerns with vaccine hesitancy, people who have very legitimate reasons not to trust massive government public health campaigns or the medical establishment. And most of what I found is just talking, like there isn't like a top-down solution that you can just implement. It's just person to person talking things through and listening to concerns, because a lot of concerns are completely rational, reasonable concerns that need to be heard out. And that is a topic, like we could talk for hours on that. So I would love to address that more, but it's there. There is a question about what treatments are available to treat cytokine storms associated with COVID illness. Cytokine storms, for those who haven't heard, is a late stage problem in COVID infection, where basically your body's immune system basically brought to the edge of defeat goes nuclear. It basically scorches the body in its attempt to destroy the vaccine, to destroy the virus, and in the process probably kills you. This was actually how a lot of deaths in the 1918 flu pandemic happened, when it was mostly younger people who were dying because stronger immune systems were basically killing their people. So we actually have a drug called dexamethasone. It's actually a steroid that's existed for decades that they repurposed and found that it actually is an immunosuppressant. It lowers your immune response, which seems completely backwards when you're fighting off a viral infection. But at the late stage of infection, then your immune system has gone haywire. This is I compare it to the end of Avengers, when the government tries to blow up the city because aliens are attacking, and they have to get the bomb out before they do that, so they win there. Yep, and I think Megan, you're going to jump in there. I think we're running tight on time.
Yeah, we're doing great on time, and I know that there are more questions coming in, but I just wanted to continue with a little bit more information and give Sean a little bit of a break. I was like, this is a group of pastors and church people. They're not going to ask you any like huge scientific questions. You guys are smarties. This is great. So just to take it in a little bit of a different direction for a minute, knowing the science and understanding kind of how this works is one part of this, but the other part of course, is the values that we hold as communities and how we lead a process that's based on our values. I know just like almost just a year ago now, we were having webinars about what is COVID and what does it mean for the decisions we make about being together in community. And so here we are still kind of continuing the same conversations, right? As information continues to change, as we continue to learn new things, how do we think about what it means to be a community and to be together? So a few things just to consider. I'm really following on Cindy's model from last spring where she just raised some questions. Here are some things you might want to consider. First is thinking about this in terms of risk management. It's going to be who knows how long before anything is safe. So as we think about communities, what the question we're really asking is what level of risk is acceptable in our community? And that might be different for different people, and the levels of risk might be different also in different places. I know colleagues who have churches that are mainly people who are over 65. And so it might be sooner that all of their people are vaccinated than a church that has more young families. And what does that mean about the level of risk to consider when you think about gathering? Also, a question to think about is who is most vulnerable? And we've been asking this in terms of infection and mortality first, right? Like who's going to be most vulnerable to COVID? Who's most at risk of complications? But now we can start asking this in other terms as we think about getting back together. Who is most vulnerable in terms of isolation? If a community decides we're going to start with 10 people in a church on a Sunday with the windows and doors all open, you know, potentially part of the conversation is who most needs to be back in this room. Schools have done this a lot, right? The kids who had the highest needs were the ones who were prioritized to be in person. So that's just something else we might want to consider. And as we're thinking about all of this, I want to plug also the webinar that Eric Doss did for us. Was that months or weeks ago? What is time? I don't know, but it was about hybrid worship. And it was a really beautiful webinar because there was no shame or like, you have to do it this way. He was super helpful in thinking about what are the different ways we can continue to connect with people, both in person and at home, whether it's just in the short term or over the long haul. Also to consider, what are our theological values and our convictions? So who does our faith instruct us to privilege as we make decisions about regathering? The 1 Corinthians piece about everything is lawful, but not everything is beneficial has been an important scripture in my congregation. So it might be okay for me, but what does that mean in terms of how we make decisions for the community? And thinking about the values of your community and how they can guide you. So my church has been long at work on building an elevator. Our sanctuary is on the 2nd floor. And we did a whole lot of work identifying our values for our worship space. And the first value we named was that everyone can see, hear, and participate. And that value has guided every decision that we've made throughout this process, throughout this past year. And so identifying what your values are and leading from there might be helpful for you all too. And the last thing I want to just ask you to consider is that we have all been living in an unprecedented time of high stress. We don't even know what effects living in high stress for this long has on people. Like there aren't even studies because it's just not a thing that has happened on this global scale before. So if you are like me, I've been a hardcore kind of person who's, committed to public health. And I've been like the wet blanket for all these months telling couples they can't get married in the church, all of those things. And I'm tired. I'm really done. And I wonder how that feeling of being exhausted from this really complex kind of leadership for so long is going to shape our return. Are we going to just reach a point where we think, I can't, just fine, forget it, let's do it. And that's really not the process that we want to lead, right? So just to tell you a little bit, high stress is very normal in a disaster, but usually a disaster is something like a hurricane or a tornado that has an impact date, and then we recover. And we're kind of stuck in this trying to recover phase while still being in the middle of the impact. And we're coming up on a year anniversary, which is also a time for spikes in stress and in all kinds of emotional reactions to what has happened. So stress, there's like good stress that helps you to get done what you need to get done to meet your deadlines. There's kind of tolerable stress that's at like the very top of your window. But when stress gets outside of this window of tolerance, it becomes toxic, and toxic stress begins to have effects on us. We start having emotional outbursts. We are having this COVID brain fog where we can't remember things or think clearly, right? Where we're having interpersonal difficulties. Sometimes we're noticing physical symptoms. There are so many ways that high stress can affect us, more than we've even ever imagined before. And it's really important for us to acknowledge and to deal with this in our own lives as leaders, and to help the people in our congregations as well. So a few things on just dealing with high stress. Something that happens in times of high stress really is that your prefrontal cortex that helps you clearly think those nice organized thoughts goes offline, right? So that the survival parts of your brain can take over and keep you alive, which is super helpful if you're being like chased by a lion. But if you're experiencing this day after day after day for a period of a year, it's really going to affect you. And I think recognizing all those things, like it's hard to focus, I'm snapping at the people I love, I feel more tired from things that didn't used to be so hard. All of those are signs that our brain is doing what it's supposed to do to keep us alive, to survive in this time. Even putting on a little bit of weight can be a stress response that our brain is programmed to do for us. So I think, often we feel like, oh man, especially looking at other churches and what they're doing, right? We're not doing this thing. We're not producing this high production value music. We're not doing this other program. And what we should be thinking is, wow, we are surviving an unprecedented global pandemic together. Good job. Positive thinking is one way of coping. Just to review with you guys, there are lots of ways of coping with high stress. Grounding exercises like prayer, meditation, breathing, those can be important. Connecting with other people. I know for some church leaders, connecting with the church community is maybe a source of stress right now because it involves tech and negotiating opinions and all kinds of things. So maybe finding some other connections that are outside of what we've been used to relying on is what we need right now. Self-care, again, I like to differentiate this from self-soothing. We all know the binge watching on Netflix while drinking wine, self-soothing method, but self-care I like to think of as anything that helps make our lives something we don't have to escape from. So these are the things like drinking enough water, eating food that we know is good for us, getting some exercise, drink your glass of wine while you watch Netflix, but just also have a glass of water as well, okay? These are the kinds of things that are gonna really help us to survive in the long run. And finding the ways that you can have some fun. There's a lot of work, right? There's a lot of things to do, especially when your office is now in your home. And finding ways to have boundaries for fun, for play, for creativity that's not for work, and connecting with others can be super helpful. And then lastly, I just want to, again, remind you about the resources that are available to you through this crisis counseling program. We would love to do some self-care coping groups with folks in Massachusetts. If that's interesting to you, let me know in the chat and we will talk about that more. But please reach out, even if it's not to us. I don't know if you have a therapist or a spiritual director. This is the time to really take care of yourself so that we can lead with some intentionality and commitment to our values. So as Sean said, there's the vaccine town hall coming up. This has been recorded and we'll send this recording out if you'd like to share it. We'll also do a follow-up discussion in 2 weeks. And I think those are all of the little announcements that I have to share with you. Again, if you want to be connecting with us in any of these ways, I highly recommend Sean's weekly updates on YouTube. If you want to stay in the know with a little bit of humor and a lot of clarity, those have been great. So I'm going to stop sharing right now. It is 11:54. We have time for maybe one more question. Sean, Mark Dayton has asked, are church potlucks gone forever? Can you speculate?
I'm going to say no. There's a little ways out. But first of all, any outdoor event is always going to be safer. This summer is likely to be a much better time, both because we'll have a lot more people vaccinated. It'll be easier to be outside again. And a lot of people have forgotten, at least here in Massachusetts, summer was not that bad of a time because we could go outside. You could go to the park and hang out. You could see friends from a couple feet away, and it was fine because transmission is so much less likely outdoors. So certainly the outdoors church potluck will likely return sooner. But hopefully, by the fall, pretty much everyone will be vaccinated, and we can have life more or less as normal. Variants may throw a wrench in that, but again, we can likely put together any booster shots we need in that time frame, and it's entirely possible that if we can get on top of this enough in the next few months, it won't be much of an issue. One or two questions there. Any more time still, or people have to go?
One or two more, yeah.
Okay.
We have until noon.
Okay, so real quick, Richard asked about diagnostics, PCR versus antibody tests. So PCR tests are the kind that are the most available and effective as diagnostics. So PCR are the ones where they take the swab in your nose or your mouth. They don't have to stick it all the way to the back of your skull anymore like they used to in the early days. And those are the gold standard for finding out if someone has COVID or not. An antibody test is a blood test that will tell you if you have had COVID recently. It's not really useful for diagnostics, but after the fact, it can be very helpful to see if you were infected or not. It won't test positive forever. So if you had a mysterious cold last spring, it's probably not going to tell you anything on that. There's also a third type, rapid tests or antigen tests, which we don't see a lot of, unfortunately, because people don't quite understand them. But they're the kind of test that takes like 15 minutes instead of like about a day and a half, like a PCR does. And those don't tell you if you currently have COVID. They'll tell you if you're currently infectious, basically. So if you were exposed yesterday, took a rapid test today, it would probably come back negative. But that's the kind of thing that's good for, say, testing before you do something. So you say, I'm testing myself before I get on this plane. I'm not sick on the plane. Okay, I'll test myself tomorrow with that before I do something else. And then there's a question about getting leftover vaccines from a vaccine clinic. So there's an issue with vaccine distribution. They come in these little vials. And once you open a vial, you can't put it away. You can't put it back in the freezer for tomorrow. So if the end of the clinic comes and there's still doses left in that vial, Pfizer usually has 5 or 6. Moderna has 10 or 11. They're supposed to be 5 and 10, but sometimes if you really want it, you can pull an extra dose out of there. I've managed that a couple of times. But so at the end of the clinic, you've gotten through all your scheduled appointments, and there's sometimes a couple of doses left. The question asked if there's a way to find out if there's some less, and unfortunately the answer is usually no, because you usually won't know until literally the last couple of minutes of a clinic how much is left. I've vaccinated a couple of people myself, and at the hospital where I work, at the end of the vaccine clinic, we had 3 doses left. We had to call every clinic and every unit in the hospital to find someone who hadn't had their vaccine yet, who'd come down and get their shot. Otherwise, we'd have to throw them away because they wouldn't be good tomorrow. Is the problem with these vaccines. That won't be the issue with Johnson & Johnson. So that's an exciting thing about that, because that you can just throw it back in the fridge. But you won't know because it depends about basically if people don't show up to the clinic, if there's just like there's gaps, or if people find extra doses, or if someone drops one of their syringes and has to waste a dose or something. If you drop the syringe, you could just take off the needle and put a new one. That's a bad example. But so it's really, sometimes people will will come to a clinic when they've had an appointment, and like their partner will be in the car, and they'll just ask, hey, do you have any extra doses today? The last clinic I was at, we didn't, but people were asking anyway. It doesn't hurt to ask if you're happening to get going in and you have someone with you. And that's, but yeah, it's very hit or miss. And hopefully no clinics are going to be throwing away doses because they don't have any people to vaccinate. But it's very much luck of the draw. You may just be in the right place in the right time when someone says, hey, you come get vaccinated so I don't throw this away. But it's hard to plan on at this point, it's too, like the way the vaccine sign work, it's too hit or miss to really be able to keep track of that. And in a couple of weeks, it probably won't be an issue where we'll just have enough doses out there that it's just people can come in, just as fast as we can get shots in the arms.
Sean, you may not know, one of the theological convictions that defines Presbyterians is this idea of the total depravity of humankind. Like, anytime the system is kind of a mess, we're right there with Calvin. None is righteous. So I'm just gonna close our time together with a little prayer, and you guys can go off to whatever is left of your day, whatever's ahead of you. So will you join me in prayer? Eternal God, you roll out the heavens like a carpet, naming the stars, making sure not one is missing. And your sight is the end of this pandemic. Remake us now in your own image, that we might demonstrate courage in our care for one another, doing all we can to make sure no one is lost. Help us to guide your people. Give us clear paths in our discernment. Keep us safe as we labor to serve you. Surround us with your peace, knowing we have done what we can. And in the end, this church belongs to you, Creator and Redeemer of all. Amen. Thank you so much, everyone, for joining us. We really appreciate it. Come back in 2 weeks to talk with Carl and I more about what's happening in your community. Take care.
Thank you, Megan. Thank you, Sean.
Thanks, Larry.
Yo.
It's always nice to have a couple really engaged Zoom audience members, which I feel like Larry was